999,000. All right, I'm so glad that everyone could make it. Thank you so much. Today, we are hosting a webinar, How Leading Healthcare Organizations Achieve Sustainable Integrated Behavioral Health Programs. My name is James Kanka. I'm the VP of Marketing here at NeuroFlow and the host of today's webinar. Over the next 45 minutes, we are going to discuss how we launch and enhance successful integrated behavioral health programs and gain insights from leaders who have done it already. Before I get started, I wanted to share a few housekeeping items. Number one, as is the case generally, just dropped something. We will be recording this session. So if you've registered or know somebody who's registered, don't worry about it. Over the next few days, we will send out a recording to this so that you have access to it and can share it. Please share it. We love when people share it. And if you have any questions, the other thing I ask of you is please submit those. You can do so in the chat button or the chat section of this tool, and we will get to those in the last 15 minutes of the webinar. It really means a lot to us. There's a lot that we're going to cover today. There's a lot we may not be able to cover today, but if we don't get around to your question, we'll try to follow up with you afterwards. So please do so. Thanks. All right. Hopefully everyone's here, ready to get started, because today we are joined by Christina Fixari, the Senior Director of Behavioral Health at Ascension, Sarah Hanchett, the VP of Clinical Operations at Evolved MD, and Dr. Tom Zobler, who is our Chief Medical Officer here at NeuroFlow. Let's get started just by having some quick introductions from everybody. Christina, would you mind sharing just a little bit more about yourself and your role or your organization?
Sure. So I'm Christina. I'm a licensed clinical social worker with about 20 years, 23 years, if I'm really honest, experience in the behavioral health field. My role for Ascension is I'm the Senior Director of Behavioral Health that was hired to drive forward the strategy of integrating behavioral health into the primary care setting. So that's what I do.
Sarah, how about you go next?
Sure. So at Evolved MD, we focus solely on integrating behavioral health into primary care. And in my role as VP of Clinical Services, I oversee our entire clinical team. So that includes about 55 behavioral health managers right now, 10 clinical supervisors, 10 care coordinators, our clinical directors, as well as our training team. So I am also an LCSW like Christina, and I have about 24 years experience in the field, which is a little nuts.
Go ahead, Tom. Sorry.
Tom Zobler. I was going to say, I think I got you guys beat. I'm feeling very old, so I've been immersed in the world of behavioral integration for almost 30 years. So it's a sobering number. So I'm the Chief Medical Officer. I'm a psychiatrist, Chief Medical Officer at NeuroFlow. Prior to NeuroFlow, I was a department chair for 21 years, and you'll hear more about all of our experience, but have been engaged in the world of integrating psychiatry and behavioral health into primary care and specialty settings for a very, very long time. NeuroFlow is a health technology company that provides the digital infrastructure to integrate psychiatry and behavioral health into a multiplicity of settings, including primary and specialty care. I think of us as really the conductor of a symphony that allows us to have a synergy between providers, payers, and of course, patients at the center of a universe of care to ensure that there's universal access to care, behavioral health care, and behavioral care outcomes are as robust as they can possibly be. Pleasure to be here today.
Well, I'm glad we could all get together. It's really exciting to have you. This is an important topic, and I have a few questions ready for you all, but it's great that I think we work with both of you, Christina and Sarah, in NeuroFlow, so I think there's a lot of opportunity for us to talk about that. But generally, as organizations are thinking about this, can you give us some background into what programs you've started and what kind of populations they served and how that might have changed as you've done one or two of these?
Sure, happy to. Let me step in first and then I'll hand it to Sarah. But So in my previous place of employment, I was lucky to stand up a number of integrated interdisciplinary programs. I think one of the things I learned through that I do want to call out is that providing healthcare to a patient really does take a team. It's a team-based sport. And so in my previous organization, that's really what I focused on doing. So there were two of them. The first one was we had a gerontology psych assessment team. So the population we focused on was those 60 and older, which were beginning to experience memory loss. And it was an interdisciplinary team utilizing nurse practitioners, pharmacists, social workers, and primary care. And then we had that consultative approach with neurology and psychiatry to address dementia and very specific needs. We focused, on the diagnosis, but we also focused on caregiver support and recommendations for medication management. The second one that I implemented and stood up was our interdisciplinary pain clinic. And it was very, very similar. The focus was to assist with safe opioid prescribing, as well as helping the patient with management of chronic pain and finding new skills to cope with that. That team was comprised of physical therapy, social work, psychology, pain management physicians, but also then had the consultative support from psychiatry and addiction medicine. So those are the two that I started with. Currently standing up collaborative care at Ascension, and that's how I partner with Neuroflow. Sarah.
Yeah, so previously I did some work to integrate behavioral health at a pediatric clinic, but this was more of a co-located model. And so it had varying degrees of success. Yes, it improved access to care for patients, but it still came with too much stigma related to mental health. So since 2017, with Evolved MD, we have been doing psychiatric collaborative care directly in primary care offices. And I think what's unique about this compared to the programs I had tried before is we are integrated directly in those offices. So we have a space that used to be an exam room. We look and feel like a member of their team. So patients at a doctor's office don't know who Evolved MD is. We just become part of the team there. So I think that's been a really important part of what makes our current program so successful. We essentially will serve any patient, any acuity level, and from geriatric to pediatric. So if it is a patient on that PCP's panel, we would love to be a part of that care.
Thanks. And Tom, you work with Neuroflow now, but if you've done this before, can you share?
Yeah, thanks, James. So as I was saying, I've been doing this a long time, and maybe I'll start when I was a fellow on the faculty at University of Washington in Seattle. That was the birthplace for collaborative care and a lot of the work that was done in behavioral integration. I was very fortunate that my mentor there, a guy named Wayne Caton, was literally the person who started the whole collaborative care movement. So I've been immersed in that world ever since. It's a sobering statistic that we have been embarked on this journey for so long, and yet the uptake of behavioral integration and collaborative care is still relatively sparse. And that's a part of what we're talking about today, and I think the impetus for this webinar. I think back to my career and think about different models of care that are out there. I remember when I was on the faculty at Georgetown in DC, I was the psychiatrist in a primary care practice, and literally it was in a strip mall next to a Black & Decker shop and a McDonald's, sandwiched in between the two, and I was the psychiatrist. I loved it. I provided the care, and it was terrific. It's not a scalable model is the problem. And so, really got into, and my background, in health services research and collaborative care, got into looking at population-based models of care to deal with the workforce capacity issues and so on, and have been seeding a whole range of behavioral integration and collaborative care models of care all over the place. Most recently established in a very large multi-specialty, 1,000-member physician multi-specialty medical group, a large collaborative care network there. Ironically, I was looking for a partner to scale that, a technology partner to scale that program, because it's really tough without the technology to do that. And that's how I came to NeuroFlow. And my former health system is now a client of NeuroFlow's. So happy to share more about that. But that's, my journey is taking me to many places and many types of behavioral integration, primary care, specialty care, a whole range of settings. And we'll talk more about that in a little bit.
Great. So we've established that you guys have done this before. So the question is, as organizations here have already started it or they're beginning the process, there's a lot of things to consider. When you first launch a program, an integrated behavioral health program, you have to think about staffing and training, financial opportunities, how it's sustainable within an organization. But before tackling all of that, what's the very first step that you take to develop a program? And Sarah, let's start with you this time, if that's all right.
Yeah, that's great. So I appreciate it. As we were getting to know each other, we talked a lot about how we need to focus on what is the issue we're trying to solve for, right? So we really need to figure out and have organizations decide what are they trying to accomplish. Otherwise, we do sort of a shotgun approach and we try all kinds of things and nothing really sticks. But really understanding what are the issues you are trying to address, and then that will help solidify what is the model that you want to go forward with, and then learn as much as you can about that model.
Tom, do you want to go next?
Sure. So I think a first step, and Sarah, I completely agree. I mean, I think a first step is really understanding a mission and a vision for the organization that we're working with, and we want to see how that aligns with how they're managing behavioral health problems, and how managing behavioral health problems not only helps to treat psychiatric illness, but it helps to improve the well-being of anyone attributed to that health system. Because, as we all know, you can't have health and well-being without mental health, and it is ubiquitous. So, it's psychiatry and behavioral health is one of the few areas that really interdigitates with just about every aspect of medicine, and we see how it drives increased costs, and how it drives increased utilization, and how it leads to increased morbidity and mortality. So it's really important to align on mission and vision and quality initiatives, and then talk about where a system is, if we're talking about a health system or a medical group, where they're at in terms of their level of integration, if they have any integration at all, and recognizing that you don't necessarily go from having nothing to a full-bore collaborative care model overnight. There are many steps along the way to help someone move in that direction. And it's also really important to identify who the key stakeholders are. And I know we're going to talk about that more in a second, and align there as well.
I would add on to that. I agree with both things that Sarah and Tom said. You do need to align with the mission and vision. You need to identify what is you're attempting to accomplish. You also really need to understand from the perspectives of the providers, what it is, what their needs are, as well as the patients. So the stakeholders in this are many in an integrated care model. So you really need to understand the perspective from the patient, what is going to be helpful for them, what is going to make it easy for them to access care, but they also really need to listen to the physicians who have been responsible and tasked with providing physical care, right, primary care. And now, because of all of the shortages that we have across our nation, there's not enough mental health providers, and also because of the stigma, people don't want to go to a behavioral health provider. Everybody goes to their primary care physician. And so they've been tapped into as being the person that we all seek care from. And so we really need to listen to them and what they need help with, and how can we support them.
Yeah, that comes up often for us, are the providers ready for it? Is it meeting their needs? That kind of thing.
Yeah.
So, and with that, we talk about change management. Whenever you're introducing something new, it's really easy in healthcare. No, of course it's not. Change management's really hard. So would you mind talking about, we touched on this a little bit, but when you're leading that kind of cultural change within an organization, those organizations that you've been in, how do you go about rolling it out? And particularly, how do you roll it out to the key stakeholders that need to be involved and to get everybody on the same page? Is there one that stands out? And who else is working with that in that process? And whoever's ready to go first, please jump in.
I'll start. And so when I think about when I implement something like this, is it so important to cast your vision of what you're attempting to do and carry that story with every contact, with everybody you come across, and all the time. And so you've gotta always be communicating what you're attempting to do, where you're at with it. I think that's key. And so it comes back down to communication, receiving feedback, adjusting where needed, but always carrying that story forward of what we're attempting to do.
And I would add to that to make sure that the storyboard includes that why. Why are we doing what we're doing, right? At every single level. So when we're talking about change management in, say, the sense of a doctor's office or a singular clinic, it's important to take that storyboard and that why and that vision to everybody, not just the providers. Yes, they're important as well, but it's the front desk, it's your MAs, it's the office manager. And so everybody needs to be involved in understanding that vision and understanding how their specific role and things that they are going to do within the model, whether it's psychiatric, collaborative care, or other, how that is going to reach the vision together.
Yeah, and I agree with everything that's been said. I would add a couple other things. You know, the culture of healthcare is such that you know, it's really a culture of scarcity, and whether it's a scarcity of time, scarcity of financial resources, these are omnipresent, right? So we have an RVU-based system, even though there may be some value-based care arrangements. Still, most institutions and physicians are RVU-based, and that has implications for physicians as well as CFOs and financial stakeholders in different models of care that could be adopted or not. So what we see is often people feeling burned out, people feeling overwhelmed, systems that have just made a transition to a major electronic medical record system, invested, you know, $200 million, and they don't feel they have the bandwidth to take on something else, or physicians who feel like they are spending all their time learning a new AMR, and the last thing they want is another piece of technology. And so, you know, we have to recognize that change management in the context of this culture of scarcity and feeling burned out and overwhelmed is very challenging. And it doesn't mean that that it can't be done. In fact, to the contrary, I think that implementing these models and using technology to facilitate these integrated models in some ways is an antidote to the burnout. We're very strong believers in the quadruple aim, you know, not just the 3 core aims that we all strive toward, you know, the Don Berwick aims. It's that quadruple aim of improving provider satisfaction and making sure that we're doing everything we can so that the patients who are coming into primary care offices with vague somatic symptoms, tinnitus, back pain, headache, whatever, that it's a revolving door, and that there's something that can be done to manage that revolving door so that patients are actually getting better, the utilization goes down, patient satisfaction goes up, physician satisfaction goes up. And when you're looking at this from a financial perspective, and we'll talk more about this, but there are financial outcomes that are favorable. So I think we have to recognize that there's a lot of inertia, there's a lot of burnout, and a lot of obstacles that can get in the way of any change in a culture that is just feeling besieged with demands coming from all over the place. So that's a challenge, and we have to acknowledge it, we have to talk about it, and we have to talk about why what we're offering is going to make things better.
Agreed. Could I add a little bit more onto that? I think it's also, we're in an exciting time for mental health and behavioral health. While we still have so much to overcome regarding the stigma of mental health and seeking care, there is this emerging understanding about addressing behavioral health is addressing health, and how you can't just send somebody over to this building and you send somebody over here. But really, you need to connect all of those things together, because that is what health is. So it's an exciting time, and it's great to see people begin to get on board with that. So I think that's also another really important thing, is no longer is behavioral health pushed to a separate building and let me give you a referral.
It does. It seems like a mental shift that has to happen. And we have these different stakeholders that each require almost a little bit of different messaging for providers, as you mentioned. It's making sure that we're still satisfying their time constraints that they have, that we're not adding more additional workload to them, that we're meeting a need that they have as well as the patients have. And as you mentioned, we're going to, the next question is about financial sustainability. So it's, what is the organization's needs? And so my question there is, we know that budgets are tight, and we're not doing this altruistically. Ultimately, we are doing this, but it also needs to make sense financially. So when you're presenting this in front of that key stakeholder, how do you approach it? How do you find a balance in meeting those short-term revenue needs with also a superior way of approaching medical care? And then achieving those long-term goals that you have if you're moving towards like a value-based care situation, or even remaining in like a fee-for-service type organization. And whoever wants to jump in and start, please.
I could start this one this time.
Okay.
So when we talk about sustainability, I think that means different things to different people. So we have to understand who we're speaking to and what do they mean by sustainability. So some organizations with behavioral health just need to break even. Some need a 5% gross margin. Some need something else. So we need to understand what it is that they mean by sustainability. But I do know that, as Dr. Zobler already mentioned, there is so much already going on within psychiatric collaborative care. And just with, Evolved MD over the past 5 years, we feel very confident with the correct payer environment. Inbound revenue is going to exceed cost. We feel very confident in being able to say that. Anytime we have a behavioral health manager that's going to manage about 100 patients on their panel, this is financially sustainable. And so I think there's enough data out there. It's been gathered over the long term. Thank you for starting that out, Dr. Zobler, many years ago with University of Washington. But it is possible. The other thing that we do to make it sustainable is to make sure that we aren't overloading the behavioral health clinician themselves. So our goal is to have about 5 to 6 hours of clinical patient care time, leaving 2 to 3 hours in a typical workday for all the other collaborative activities that need to happen, right? So time to talk to the psychiatric consultant, the PCPs, everybody in the office, and really maintain good relationships within an office. But it's balancing everything that the behavioral health clinician themselves needs as well.
And I completely agree. I think that, and I'm going to pick up on Christina, your optimism. I am incredibly optimistic in terms of where we're going. And again, I think back to a time when there were no CPT codes for collaborative care at all, and I had to raise, a lot of money to start these collaborative care programs through grant funding, and kept on thinking, when is this going to happen? The APA, American Psychiatric Association, has been involved in lobbying on a state level and national level for these CPT codes, and it did happen. And sort of, we were all counting on that. So here's the thing. I mean, Sarah, completely agree. I think that these are financially viable models. I mean, notwithstanding the fact that we've got to do it because our healthcare system can't function if we don't have an adequate way of treating mental health. We can't have 60% of individuals in a given year with psychiatric problems receiving no care at all. That's not acceptable. It's just simply not acceptable. So we have to think about ways to improve access. We have to think about ways using, standing on the backs of giants, like my mentor, Wayne Caton, that created these models of care that leverage precious and expensive and limited resources so that you can cover a much larger population of care and have really robust outcomes. We've got to utilize those models of care to make it manageable and affordable just from a system perspective. And I'm not just talking about an individual health system, I'm talking about the entire country and the way we function as a health system nationally. So we've got to keep all that in mind. What I'm optimistic about is there are CPT codes, right? There are CPT codes for collaborative care. There are a number of states, I think there are 6 right now nationally, and it's going to grow and grow, states that have mandated insurance carriers reimburse for collaborative care. There are, I think, 26 states, don't quote me on that, but that have Medicaid case rates for collaborative care. The state of North Carolina just announced or recently announced that they're paying 125% of the Medicare rate. That's for Medicaid for collaborative care CPT codes. So, you know, that's huge. So, and I think it's hard for primary care docs and sometimes for key financial stakeholders to understand that this billing is incident to, it's not carved out of the behavioral health plans, it's incident to the primary care doctor. So other people are in effect doing the work, but it's dropped by the primary care doctor under the patient's general medical insurance. So they're not going to be saddled with some tremendous bill because it's carved out into a behavioral health plan that they don't have coverage for. So you know, that's key. The other thing that we need to keep in mind is that the real savings to a health system, to a medical group, are downstream. It's decreasing that utilization. It's decreasing the 30-day readmit rates. It's decreasing the ED visits, medical inpatient stays. We know that for every dollar you invest in a collaborative care program, and that's just one example of VHI, it's a robust example, there's a $6.50 return. So there's an enormous value proposition to doing this, and it's been shown over and over again in randomized controlled trials. So we have the evidence base. It's a matter of demonstrating how that can be utilized. And even when you don't have a value-based care arrangements, you know, writ large, there are things like the MIPS, the merit-based incentive payment system, there, you know, for screening and so on. There are ways to integrate psychiatry and behavioral health into medical settings and garner some pay-for-performance dollars from CMS and elsewhere that help to not only defray the expense of doing these programs, but actually over time, and the horizon can be a few years out, but really save hospitals and health systems and payers, you know, a good bit of money. I mean, there's an alignment of the clinical and financial there. So just a few thoughts of why I'm optimistic.
No, I think you're right. You know, it has been proven that it's a model that does pay for itself and it does generate, you know, small margins of revenue. But I also think that when our leadership agrees to fund this and takes on that risk, right? Because it is a risk, it is something new. We need to call out for them what are some of the potential risks associated that could cause it not to pay for itself. And some of the risks are blurring roles so that we can't optimize the care manager role to care the caseload that they need to care, right? They'll add this as another responsibility on somebody who already has a full workload. And when you do that, the model doesn't pay for itself. You can't reach those efficiencies. I think another risk to call out is when you don't have buy-in from the primary care providers to make the referrals, right? We've had this model up and running in some areas that I work in, and the number of referrals to the program are fairly minimal. And if primary care doesn't refer and doesn't do their part, that is also a risk. So it's ensuring that we call those things out. And I think the final thing is, if we, as Tom said in the beginning when he was introducing himself, if we don't have that technology that is needed to keep us efficient, then we're spending so much time in the administrative pieces that we can't be effective in managing the care. So I think calling out those risks are just really, really important for our leaders.
Great points. So we're getting close to Q&A time. So if you haven't submitted a question and you want to, please do so in the chat. I want to follow that up with, it's a little off script, so I'll start with my own Q&A. You mentioned technology, so hopefully you guys are prepared to answer. How has technology, since you've been involved in integrated care programs over a long period of time, how has technology transformed or made it more sustainable and scalable? And right now you're working with us, but you might be using some other technology. Would you mind touching on that and kind of what you've seen developed over the last little bit?
Sure. So I'm going to go first on this one. So my past experience was with an organization that used the Epics Healthcare EHR, right? And so we were able to leverage that to develop a registry. There's no way we could have had an interdisciplinary pain team or the efficiencies of our generic psych program without that registry. And that's exactly one of the things that I identified when I came to Ascension is we were missing that. We had multiple different EHRs. Our care managers were documenting in one for patient care, they were documenting in another for case management, and none of them was a registry. We were actually in some places using Excel spreadsheets or paper and pencil to track how many times we had outreach patients, and it was difficult to show the changes and the outcomes and were people getting better or not, and who should target treatment. So that's exactly why we sought out the relationship that we did with NeuroFlows, because you had all of that and more. So it's been key.
I agree with all of that, Christina. When we started out with our Excel spreadsheet, right, it looks very high tech. It's better than paper and pencil, but not much. And then, but yeah, it does make it challenging to really track progress over time. So we've had 2 different iterations of technology since then. So currently in working with NeuroFlow, yeah, we decided to choose that platform because of the patient registry, the tracking progress over time, and just really being able to manage a patient population rather than a singular patient. And having the ability to engage patients outside of their actual, clinical sessions, also important to give patients the ability to own their own treatment and engage in their own progress. Really important and meaningful for our team.
Hey, Tom, I'll let you speak to this a little bit because you've been doing this beforehand. You obviously joined NeuroFlow for a reason, but if you give a little bit on that tech-enabled collaborative care that you will often discuss.
Yeah. So thank you. So agree with everything that's been said, and I might have something to say about technology in this area. So the reason I'm sort of laughing to myself is that I'm old enough to have written every single term paper with a typewriter when I was in college. There were, when I graduated from college, there was the Fat Mac, and that was a really big deal. And I guess for medical school, I think I had a computer, but not for college. And scaling collaborative care, scaling behavioral integration models without technology is like using a typewriter today instead of a computer. It's really, really tough. I mean, I think that we're all talking about the same thing, that in order to provide good care in any setting, you got to make sure that it's measurement-based care, right? I mean, that's just a given, that we're clinging to evidence base and that we're making sure that we're looking at patient-reported outcomes and we're tracking them and making sure the patients get better. And if they're not getting better in a step care model, that we're doing things to make sure that patients will get better. In any model of care you have, that's critical. If you look at behavioral health in general, sadly, the amount of adoption and standardization of measurement-based care is pretty low, lower than in a lot of other fields. I mean, these, what we call the cognitive specialties, psychiatry, internal medicine, and so on, it's been challenging to really incorporate measurement-based care, but we've got to. So technology, first of all, can help with those assessments. It becomes much easier to do these assessments when it's in the comfort of someone's home, whether it's in an app, out of an app, whatever it may be. And this notion of what's referred to as ecological momentary analysis. Basically the idea is that capturing people in their homes when they're in distress is meaningful and important. Sometimes there is a difference in how patients are going to endorse depressive symptoms, anxiety, and so on when they're in their homes versus in a doctor's office. So 1, you're getting a more complete and accurate picture of how patients are doing. 2, you're also getting to see when patients may be at need and even at risk, and things can be done to mitigate and manage that risk. So one of the things we have at NeuroFlow is what we call response services. If patients trigger an urgent alert because there are concerns about safety, we'll reach out to the patient with an email and then a direct reach out with a response service coordinator, or our clients may have their own people that are designated to do that, and you can intervene. And those caring touch points, the caring contacts make a difference sometimes between life and death. So it's that continuous monitoring and making sure longitudinally that patients are getting better. And if they're not getting better, you can make adjustments in the level of care. The technology allows all of that to filter from these assessments into a registry that enables the primary care docs, psychiatrists, behavioral care managers, behavioral consultants, whatever the model is, everyone to operate at their top of their license with just enough information, not too much, because that's the key. You don't want to flood people with too much, but just the right amount of information so that everyone can operate intelligently and thoughtfully. That's why I keep on thinking about, creating that the digital conductor of a symphony of care. You can provide care and integrated care, and I've seen it done. And if it's not well done, sometimes it's really bad. You got to make sure that there's the infrastructure and the scaffolding to make sure that the care is well done and that there's a conductor. And it's a combination of high tech and high touch. I can go on a lot about that if there's time, but I want to leave time for questions.
Yeah, we do have one question, so let me ask it here, and feel free to modify it a little bit if you have a better way to approach this. The question is, how do we integrate behavioral health solutions to address the minority of high-cost patients who often struggle with compliance, social determinants of health, and not having adequate access to technologies that are required in order to execute a majority of the solutions being discussed? So do you guys, how would you address that? Christina, let's start with you, if that's all right.
Sure. So I think a key thing is, yes, the care manager needs access to technology, but we can provide this care without the patient having access to it. So if they don't have a smartphone, which there are, a portion of the population doesn't have it or doesn't have access to wireless care, there are ways to work around that. I think the biggest thing is developing that relationship and engaging that patient through using motivational interviewing skills and getting them involved in their care and supporting them to make these behavioral health changes. And just, that's key. That is key in my mind to it. The technology is absolutely required for the care manager and the treatment team, but you can work around that for the patient. Sarah, what would you say? Yeah.
Yeah, I would agree with that. If you start with the relationship, just like you're going to do in any good therapeutic care, then if the patient can access the technology, great. If they can't, that's fine, because the care manager is going to, the whole team is going to, we're going to have the high touch points that Dr. Zobler talked about. That is what is needed in order to move a patient and to help them progress. We can also intervene. I think SDOH screenings become very important. We can do that within technology, whether or not the patient can access that, and make sure that the patients are receiving any of the services that they need. So I think when we think about integrated care, yes, there's certain models of integrated care, but it is so much more to have a truly integrated program. And I think that's one of the reasons why some programs maybe flounder, because they've hired a great clinician, right, who understands the vision, and we think that's all that's needed. But organizations have to be committed to the entire infrastructure in order to make a program successful. So it's more than just one piece of technology. It's more than just one good therapist. We need the entire infrastructure in order to support patients and their progress.
Yeah, and again, agree with everything that's been said. First of all, it's a great question, so thank you for that question. I'm going to break it down into two different things that I think were intrinsic to that question. One is managing this population of distressed high utilizing patients. So these are the individuals, the 5% of the population that accounts for 50% of all healthcare costs, right? Or the 20% that account for 80% of all healthcare costs. I mean, the distressed high utilizing population is key because somewhere between 60 to 80% of that population have underlying psychiatric illness. And we know, by the way, that most patients with psychiatric problems, with behavioral problems, do not present in behavioral settings, right? They present, 60 to 70% of patients with psychiatric problems present in medical settings, and yet 95% of all mental health providers work in essentially siloed mental health settings. So we got it all wrong. I mean, there has to be a realignment there. So managing that distressed high utilizing population, it is absolutely critical to integrate care. So that was, I think that's such an important thing. And if we don't do that, our healthcare system can't survive. Bottom line. We know that if we treat diabetes, if we treat, when we're treating heart disease, a whole range of things, if you don't treat the underlying psychiatric illness, patients don't do as well. I don't have the time to go into all the studies, but there are so many of them that point that out. The other thing that I'm hearing is that, yes, I mean, in that population, distress high utilizing patients, you have disenfranchised individuals and communities of individuals where there has been tremendous inequities in healthcare, right? We know that. There's structural racism built into healthcare. There are disparities that are unacceptable, and we have to do something about that. And so you have populations that don't have broadband access, that don't have smartphones, and so can technology be helpful? I mean, so there are limits, obviously, to what technology can do if people don't have access to other things, but primary care practices can attempt to track things like claims data, can do outreach through positive assertive community treatment and so on. There are things that can be done with the use of technology. When an individual without broadband access comes into a medical practice, there can be an opportunity to use a kiosk, for example, to assess how patients are doing, to provide those social determinants that are directed specifically to that individual in the community they live in. So technology can be leveraged even when people don't have access to some basic needs. And I view technology as an equalizer. I view technology as a way to provide care that is more equitable and to deal with some of the biases and limitations of how we conduct care presently. So I think those are two really important points. I'm sure there's more to that question, but those are the sort of the two things that I was hearing. Really, really important.
Yeah. Well, is there anything anybody wants to add to that? We're not going to be able to get to all the questions today, unfortunately. We only have a few minutes left, but I wanted to leave some time for you to either discuss quickly, what are you excited about with your current program, whether it's expansion, anything you're measuring that you're looking forward to learning more about. And then I just wanted to give a plug, if we end up going a little bit longer, is that we are having a white paper on this topic that we're releasing in the next week or so, and it will be going out to everybody that's registered for this. So stay tuned on that. That comes along with the recording. And I also want to say thank you again for joining us. But Christina, would you start? Let's start with Christina and Sarah. What are you excited about in your organization? What kind of things are you measuring for success, that kind of thing?
Sure, very excited. After being at Ascension for 2 years, we're finally developing some traction on collaborative care through our partnership with NeuroFlow. We're really leveraging that. So expanding access in our Michigan market, it's phenomenal what they want to do there. But I think what really excites me is recently I'm hearing leaders talk about collaborative care and how it addresses the gaps in our behavioral health services. And they're starting to get behind it and understand it and are driving for it. So I don't know, last couple of days, that's been beautiful to hear that. So I'm going to leave you with that.
That is exciting. Sarah.
Love that. So we have our team members share mission moments every week, if at all possible. And I love reading those stories. So one relates to what we were talking about earlier, when PCPs have patients that are frequently coming in and they aren't getting better with their physical health. They recognize that sending patients to our behavioral health manager and having their underlying behavioral health issues addressed, they stopped coming in so often. And the providers were so excited about that, recognizing the deep value that these integrated services were bringing. So they started sending more patients, which is so exciting, really good. So at EvolvedMD, looking forward to just continuing to expand that access to care. We're going to be growing into Denver in a month, New Mexico a few months after that, and then just bringing on more states as quickly as we and other health systems are able to move. So that is really exciting.
Thank you. It's great having you join us. And then Tom, do you want to wrap us up? What are you excited about?
Sure. I mean, I agree. Obviously, we're very fortunate to have you guys as partners, and really appreciate the work we do together and how we're making the world a better place, which is one of the things that's in our vision. I think that an area that we're leaning into a lot at NeuroFlow is suicide prevention. So I just want to take a second to talk about that. I mean, completely agree that there's, I think, cause for optimism. There's greater adoption of these integrated care models, but the suicide piece, I mean, first of all, we all know that the numbers are growing. We know that the vast majority of people who die by suicide have seen a primary care physician within the past year. I think it's 40% in the past month and close to 80% in the past year prior to the death by suicide, as opposed to a much lower percentage. I think it may be 30% in behavioral settings. So it's really important that there's suicide monitoring, suicide risk assessment, suicide mitigation efforts that are occurring in medical settings, not just primary care. And we're really leaning into that space through innovative partnerships and models. We recently won the Mission Daybreak. It was a VA award to look at innovative models to try to prevent suicide. And frankly, one of the reasons that NeuroFlow got started is because our CEO and our co-founder was a West Point graduate, was in the military, lost a platoon member to suicide when that platoon member returned to the States. So it is very, very much front and center. So we're doing some exciting stuff in risk mitigation, risk assessment, risk mitigation in the suicide prevention space in primary care. So I think that's an area of much further growth and potential.
Well, thank you everybody for joining us. Thank you, Christina and Sarah and Dr. Tom Zobler for joining us. I hope we can do this again. There's a lot more questions that I have, so maybe we can do a follow-up at some point, but thank you so much. Learned a lot. Thank you all for joining us. Stay tuned for the recording.